Hello and welcome to this Chanel CPD session. My name is Jonathan Moore. I'm a veterinary surgeon and a product support manager for Chanel UK. Today I shall be talking about inhalant anaesthetics in companion animal practice. I shall be focusing on the use of sevoflurane and isoflurane in canine and feline general anaesthesia. This presentation is designed for veterinary professionals and is part of Chanel's ongoing CPD series, which covers disease states relating to the products in our portfolio across both companion animal and equine practice. More information on additional CPD content is available at the end of the presentation. These are the topics we shall be covering. I shall begin by discussing a general overview of anaesthetics before moving on to inhalant anaesthetics in more detail. And in relation to inhalant anaesthetics, we'll discuss factors to consider when selecting gas type. We'll look at MAC or MAC. We'll examine some of the adverse effects which you might see when using these gases. And we'll look at patient factors and how these relate again to the choice and the use of the gases for maintenance of anaesthesia and how health status can affect the situation. And finally, we'll finish by discussing monitoring of patients under general anaesthesia. It should be noted that in the UK, sevoflurane products are only licensed for use in dogs and cats. This contrasts with isoflurane products, which are licensed for use in other species, such as horses, ornamental birds, reptiles, and small mammals. However, for the purpose of this presentation, because we're comparing the two products, we shall only be focusing on canine and feline applications. If you wish to discuss off-license indications, please contact either myself as the technical support vet for Chanel, or speak to your territory manager, who will point you in my direction. So what is an anaesthetic? Well, the term anaesthesia comes from the Greek word anaesthesia, which means without feeling or without sensation. Anaesthetics can be divided into two types, general anaesthesia or GA and local anaesthesia. General anaesthesia is defined as a reversible loss of consciousness, whereas local anaesthesia is a reversible loss of sensation from a localized part of the body without necessarily affecting the consciousness of the animal or patient. So let's go on to think about inhalant anaesthetics in a little more detail. Well, with general anaesthesia, both induction and maintenance of anaesthesia can be achieved through either injectable agents or inhalant agents. In general, the injectables are used to induce anaesthesia due to their rapid onset of action, and then the switch is made to an inhalant agent to maintain the anaesthetic, especially for medium to long-term procedures. Why is this switch made? Well, when using inhalant anaesthetics for maintenance, we reduce the risk of administering an overdose. With injectables, once that agent is in the animal's body, the only way it can leave is through metabolism or use, or possibly through the use of an antidote, reversal agent. But with inhalant agents, changes can be made to anaesthetic depth relatively quickly because the agents are expelled primarily from the body via the respiratory tract. And essentially, if we have any adverse effects, we can hopefully deal with these more quickly. And again, we can have a more fine-tuned control over anaesthetic depth. Finally, with the inhalants, once the procedure is finished, we have a faster recovery from the general anaesthetic with inhalant agents. So the way in which inhalant anaesthetics produce their effect is still not fully understood. There are a number of things that are believed to play a role. They may act on the lipid matrix of neurone membranes. They are also believed to activate inhibitory central nervous system receptors, such as chloride channels, GABA receptors, and potassium channels. They're also thought to suppress CNS stimulating neurotransmission pathways, such as acetylcholine, glutamate, and serotonin. However, despite not fully understanding the mechanisms of action, what we can see is the overall effect is a downregulation of all activity in the central nervous system. So as we've said before, the maintenance of general anaesthesia is primarily carried out using inhalation anaesthetic agents. The most commonly used types in the veterinary market, certainly in the UK, are isoflurane and sevoflurane. Indeed, these are the only two products that are currently licensed in the UK for this purpose, and both come from the halogenated ether group. So of these two agents, isoflurane and sevoflurane, how do we choose which one to use, and what are the differences between them? Well, these are some of the things that come into play when making that choice. The first of which we will go on to next is the MAC or MAC. There are also other practical aspects involved with the two products, which we will look at. There's also the speed of induction and recovery. There are differences between the two agents in this regard. And finally, because we live in the real world situation, price is often a consideration. So what is MAC or MAC? Well, MAC stands for minimum alveolar concentration in oxygen, and it's the percentage concentration of a vapor in the alveoli of the lungs that is needed to prevent movement in 50% of patients in response to surgical stimulus. And this is at 1 atmosphere of pressure, so essentially sea level. A MAC is used to compare the potency of anaesthetic vapors. If an agent is reported to have a lower MAC, it's therefore more potent, because less of the agent is required in the alveoli of the lungs to have the desired anaesthetic effect. Conversely, if the MAC is higher for an agent, the agent is considered to be less potent. So MAC remains fairly stable in healthy patients. So for isoflurane and sevoflurane, and indeed all the anaesthetic inhalant agents, there are quoted MAC values that appear in the literature. For isoflurane in dogs, this is reported to be between 1.3 and 1.4%, and sevoflurane in dogs, 2.1 to 2.4%. In cats, isoflurane 1.3 to 1.9%, sevoflurane in cats 2.6 to 3.4%. So there is a slight variation depending on which literature you get this from. But I think what you can see quite clearly there is that the difference between the two agents is that the sevoflurane requires a greater concentration. Essentially, it has a lower potency than isoflurane. So how are these MAC figures used in surgery and general anaesthesia? Well, remember that MAC is defined as the level of agent where 50% of patients will not show response to surgical stimulus. This is obviously not really what we want. We want every patient to not show a response to surgical stimulus. And this brings us on to thinking about this ED95 number. This is the effective dose where 95% of patients will not show a response to surgical stimulus. And this is quoted to be between 1.2 to 1.4 times by the MAC value. In addition, deep anaesthesia is said to be around 2 times the MAC value. So somewhere in between these figures, this brings us to the idea that we can achieve the necessary surgical anaesthetic depth for hopefully the vast majority of patients at 1.5 times by the MAC value. So remembering that the sevoflurane has a higher MAC value than isoflurane, higher vaporizer settings will be required when using sevoflurane when compared to isoflurane. And this means that more sevoflurane will be used to ensure that the patient remains at an adequate surgical depth during anaesthesia. So let's bring these pieces of information together and think about MAC and the vaporizer settings. So remember, we have MAC times 1.5 that is going to give us the adequate depth of anaesthesia for the vast majority of patients undergoing surgery. So if we look at the lower part of the table here, we can see MAC times 1.5 isoflurane. For dogs is 2 to 2.1%, and for cats 2 to 2.9%, and sevoflurane 3.2 to 3.6% for dogs, and 3.9 to 5.1% for cats. And again, we can see that the vaporizer settings are going to be higher with sevoflurane when compared to isoflurane. Unfortunately, dosing is not quite as simple as this, because patient factors will play a role and alter the MAC value. We shall come on to this further in the presentation. Please note, these values are taken from the literature, and they differ slightly from the values recommended in the SPCs for Sevahel and Isovet. However, These differences are minor and largely sit within the ranges suggested in this slide. So let's think about how anaesthetic agents enter the body and how these agents are dispersed throughout the body and enter various different body tissues. Obviously, we have a keen interest in the agents entering the central nervous system because this is where they're having their desired effect. On the graphs here, we can see alveolar partial pressure on the y-axis and time on the x-axis, where 0 here is the point where the vaporizer is turned on. So when we look at how the concentration of an inhalation anaesthetic agent changes in the lungs after we turn on the vaporizer, we tend to see this distinct curve on this graph. The initial rise represents the period when ventilation moves the anaesthetic agent rapidly into the lungs and into the alveoli. Following this, the knee stage shows when the concentration increase starts to slow. The slope of this is determined by the rate of uptake of the anaesthetic agent in the vessel-rich tissues such as the heart, brain and liver. The tail section is where the concentration stabilizes in the lungs. The slope of this section is determined by the rate of uptake in tissues with relatively poor blood supply such as muscle and fat. How quickly the agents are taken up, and therefore the specific shape of the curve for each inhalation anaesthetic agent, depends on how soluble the agents are in various body fluids and tissues, most importantly, blood. So the solubility of these agents in blood is really critical to the speed of onset of their action. And this solubility in blood is defined as the blood-gas partition coefficient. And for sevoflurane, this blood-gas partition coefficient is 0.6, and this compares to isoflurane, which has a blood-gas partition coefficient of 1.4. This means that sevoflurane is less soluble in blood than isoflurane. So only small concentrations of sevoflurane in the blood are required before equilibrium with the alveolar gas concentration is reached. Sevoflurane is therefore rapidly removed from the lungs and is then able to have its effect in the central nervous system. So when we look at the alveolar partial pressure against time graphs for sevoflurane and isoflurane, we can see a key difference between these two anaesthetic agents. So as you can see on the graph here, sevoflurane's curve is steeper, meaning it's reaching its effect faster than isoflurane. So why is this? And it's all down to that solubility. The sevoflurane is reaching its equilibrium point between the dissolved gas in the blood and the gas within the alveoli of the lungs more quickly than isoflurane. It's therefore transferred to the central nervous system more quickly than isoflurane to have its desired effect. And then importantly, because these inhalation agents are primarily expelled from the body in the same way they came in, i.e. via respiration, the same applies in reverse. So when the vaporizer settings are turned down or turned off, the changes to the anaesthetic depth occur more rapidly with sevoflurane because the agent is able to leave the blood and leave the body more quickly than isoflurane. So the difference between the two agents in terms of their solubility in blood and how that relates to those curves that we've just looked at, as we say, this gives rise to the key difference between the two molecules. Induction and recovery is more rapid with sevoflurane and gives the potential for finer control over anaesthetic depth when compared to isoflurane. It also means that any adverse effects that you might see during the anaesthetic process can be reversed more quickly with sevoflurane. Conversely, it also means that changes can occur rapidly with sevoflurane. So obviously anaesthetic depth is monitored carefully in all cases, but even more so with sevoflurane, you have to be very much aware that the changes can occur quite rapidly. So again, very careful monitoring is required with this gas. This brings us on to talking about the vaporizers. So isoflurane and sevoflurane require different vaporizers. They're not interchangeable. You can't just have one vaporizer and switch between the two agents. In addition, some products require adapters to use with certain vaporizers. Indeed, we supply an adapter to allow the use of our sevoflurane, Sevohale, with some sevoflurane vaporizers. Please contact your Chanel territory manager for more details on this. Let's go on to look at another difference between isoflurane and sevoflurane and how this has an impact on the practical aspects of an anaesthetic. This difference is smell. Isoflurane has a very pungent smell, whereas sevoflurane has only a light odour. This difference makes sevoflurane really useful for masked inductions because the patient is less able to detect the anaesthetic agent that it's breathing in. A lot of animals will react adversely when they smell the isoflurane in a mask, whereas this is less likely to happen using sevoflurane. And this is very useful in these situations where masked induction is required. It should also be remembered that this difference is very useful in small furry or exotic inductions using a mask or chamber. But remember that this indication in these species is off license. So the fact that isoflurane has a stronger smell than sevoflurane can be useful in certain situations. For example, is there a leak in the circuit? This might be more easily detectable with isoflurane when compared to sevoflurane. However, we really should remember that breathing in these agents as a result of a leak is not ideal. We don't want the personnel in the immediate environment, the surgeon, the anaesthetist, anyone observing, to be breathing in anaesthetic gas. So ideally, it's not a brilliant way of identifying a leak, and other methods should be considered and leaks avoided wherever possible. Finally, when considering which agent to use, it should be mentioned that cost is often a consideration and has an impact on the decision made. So sevoflurane does cost more and you need a greater volume. However, generic sevoflurane products such as our Sevahale makes the use of sevoflurane more affordable. This allows practices and patients to benefit from the practical advantages of sevoflurane, which we just talked through, especially for those more challenging clinical patients where finer control of depth and recovery are required. Remember, isoflurane is still a great anaesthetic agent and can be very readily used in clinically well animals and in routine surgeries. So it's often just finding which situation is right for you and your practice and which one may be right for the specific patient that you're dealing with. So let's consider the adverse effects that you might observe when using these anaesthetic agents. The list here is taken from the data sheets. So you might see respiratory depression, depression of the central nervous system, hypotension, muscle relaxation, vasodilation, myocardial depression, depression of body temperature regulating centers, and gastrointestinal effects. Some of these indeed are actually the desired effects of a general anaesthetic inhalant, and essentially the effects become adverse when an excess of agent is used. So all of these adverse effects are to be expected with drugs that cause central nervous system depression. The other adverse effect which worth considering is malignant hypothermia. This occurs rarely in predisposed patients, and these patients are usually dogs. So isoflurane and sevoflurane pose similar risks of an adverse effect due to their similar modes of action. And as we've said before, adverse effects are essentially dose dependent. There may be less chance of adverse effects occurring with sevoflurane when compared to isoflurane because changes to anaesthetic depth can be made more quickly. There is essentially less risk of going to excessive anaesthetic depth when using this product because you have that finer control over the anaesthetic. So as we mentioned earlier in the presentation, the correct vaporizer setting for a specific patient is not, unfortunately, going to be as simple as 1.5 times the MAC value for the anaesthetic gas you're using. Patient factors are going to come into play. Some of these patient factors will cause the MAC to increase, and some of them will cause the MAC to be decreased. So a list here, we have aging, pregnancy, anemia, hypoxia, hypothermia, hypotension, metabolic acidosis, hypothyroidism, pre-medication use, and the concurrent use of analgesics. These will all decrease the MAC value, and therefore you will need a lower dose of inhalant anaesthetics, as the agents will be essentially more potent in these cases. Conversely, there will be factors which will lead to an increase in the MAC value, and patients with any of these factors will need a higher dose of inhalant anaesthetics, as essentially the agent will be less potent in these cases. So these factors include increased body temperature, hyperthyroidism, concurrent use of central nervous system stimulants such as doxapram, and hyponatremia. Finally, there are some factors which have no effect on MAC, which is good to know. These include the sex of the patient, the type of pain that is being experienced during the surgical procedure, such as visceral, peripheral, etc. The length of the anaesthesia has no effect on MAC. Finally, hypertension has no effect on MAC. So what does this all mean practically for our anaesthetic? Well, as we've stated before, it means that essentially you can't just take the MAC value of the anaesthetic agents and times by 1.5 to give you the required vaporizer setting for your anaesthetic. You've got to consider the patient factors and what impact these will have on the MAC value. And it's worth actually just running through these all before the surgery starts, just so you're kind of aware of the situation and how the different patient factors might impact that surgical procedure and the anaesthetic procedure. At the very least, patients will have been pre-medicated, and this reduces the amount of agents that will be needed to achieve surgical anaesthesia. Let's now bring the impacts of these patient factors into the real world and discuss some actual cases. First case here is case 1, Lord Eddard. Lord Eddard needs to undergo a dental. He's a cat, he's male, he's 18 years old, he's got hyperthyroidism, he's got high blood pressure. We plan to pre-medicate him before the procedure, and he's on meloxicam for arthritis, and he only has one eye. What will these factors mean to the MAC value in his case? I'm going to give you a couple of moments just to have a think about this. Okay, so the fact that Lord Eddard is a cat is going to have no effect on MAC. The fact that he's male has no effect. That he's 18 years old, this means that the MAC is going to decrease. That he's got hyperthyroidism, this is going to increase the MAC. That he's got hypertension, this is going to have no effect. The fact that we plan to pre-medicate him, this is going to decrease the MAC. And also that he's on meloxicam for his arthritis, this again is going to decrease the MAC. And finally, the fact that he's only got one eye, this has no effect. So overall, in Lord Eddard's case, MAC is going to be decreased. Let's move on to our second case. This is Indy. Indy is planned to undergo an exploratory laparotomy. So let's think about the patient factors for Indy. Indy is obviously a dog and a Labrador. She's female and neutered. She's 11 years old. We plan to pre-medicate her, and her pre-op bloods have shown that she's got a hyponatremia. Again, I'm going to give you a couple of moments to just have a think about what these patient factors mean in terms of the MAC. Okay, so the fact that Indy is a dog has no effect. The fact that she's a Labrador has no effect. The fact that she's a female neutered canine Labrador has no effect on MAC. However, the fact that she's 11 years old, more geriatric, this is going to decrease the MAC value. And that we plan to pre-medicate her, again, this is going to decrease the MAC value. And those pre-op bloods showing a hyponatremia, well, this is going to increase the MAC value. However, overall, we're going to have a slight decrease in MAC in Indy's case. So I think the obvious question now creeps in. Now that we know that we have these increases and decreases, how much are the increases and decreases going to impact MAC? And I think that's a reasonable thing to ask. Unfortunately, I think it all comes down to the individual cases here, and it probably depends on the severity of each of the individual patient factors. So I think in order to quantify things more, you probably need to go into these factors in a little more detail. But I think overall, we can see that adding all these patient factors together gives us an overall indication of an increase or decrease in MAC for an individual patient. And critically, the thing to do is to respond to the patient in front of you. Treat each case as an individual and make the changes necessary to the anaesthetic based on that individual's needs. Finally, we're going to go on to look at monitoring of anaesthetic depth. And this is irrespective of which agent you're using, whether you're using isoflurane or sevoflurane. The same is going to apply for both of these anaesthetic agents. So these are the 5 factors that are going to come into play when assessing anaesthetic depth. The first here is palpebral reflex, and this is typically absent at surgical anaesthetic depth. Second here is eye position. As anaesthesia deepens, the eye moves from a central position to a ventromedial position, with mainly the sclera then being visible. Essentially, the patient's going cross-eyed. However, it's worth remembering that if anaesthesia deepens even further, it's possible for the eye position to move back to a central position. And this is really worth being aware of, because if you're just looking at that to monitor anaesthetic depth, people may erroneously assume that the depth of the anaesthetic is becoming less and turn up the vaporizer settings. And this would obviously be a terrible thing to do in this situation. The third thing here is pupillary dilation. With increasing depth of anaesthesia, the pupil will become more dilated. Fourth factor here is jaw tone. This loosens as the depth of the anaesthesia increases and can be assessed by gently manipulating the jaw. Finally, we have the pedal reflex. Firmly squeezing the webbing of the skin between the toes shouldn't cause the limb to be withdrawn. If anaesthetic depth is insufficient, then the reflex will cause the limb to be drawn away from the painful stimulus. So this should be abolished once you achieve the correct anaesthetic depth, where surgical stimulation is not going to be felt. As well as monitoring the signs of anaesthetic depth in the ways we've just discussed, careful and regular monitoring of the following are also required for every anaesthetic: respiratory rate, blood pressure, indicators of cardiovascular function such as heart rate, capillary refill time, and partial pressure of O2, and the temperature of the patient. It's very useful, I think, and I'm sure most people will do this in their anaesthetics, to keep a record of these on a chart. And this allows you to see the changes and trends over time during the anaesthetic. You should be looking out for signs of respiratory and cardiovascular depression, along with alterations and decreases in blood pressure. It's important to provide thermal support early in a procedure and keep an eye on the temperature of the patient throughout the anaesthetic and during recovery. Remember that lowering of the body temperature can cause the MAC value to decrease. It should be noted that this presentation is targeted towards non-rebreathing circuits. Rebreathing circuits will complicate things as the percentage of the inhalant agent will change over time. We're not going to go into this in detail in this presentation. Suffice to say that if you are using or you want to use a rebreathing circuit, you may want to get more information on the use of these circuits if you're unclear or before you start using one. So when will you need to alter the dose of the inhalant agent that you're using for maintenance of anaesthesia? When do you need to change the vaporizer settings? Well, as we've said before, always respond to the patient in front of you and respond to the situation you're in. Through those monitoring tools that we've just discussed, watch for early signs of any adverse effects. And if you are starting to see these, make small changes and monitor the patient for the effect of those changes. Remember, changes in depth of anaesthesia can occur more quickly with sevoflurane due to its physical attributes. So keep an eye on this and monitor these patients carefully during the anaesthetic. So when might you need to turn up the gas? When might you need to increase the amount of inhalation agent that is being delivered to the patient? Well, the obvious answer here is that if the patient is becoming too light and is starting to respond to surgical stimulation. It's worth noting that if you have taken the time to ensure that you're at the correct anaesthetic depth before surgical stimulation has started through all those monitoring signs that we've talked through, then this is unlikely to be the case as long as you're continuing to monitor those signs and ensure that the correct depth of anaesthesia is being maintained throughout the procedure. It may, however, be that there is a problem either with the equipment, maybe the gas has run out, or there's a kink or something like that that is meaning that the agent is not being delivered adequately to the patient. Check the circuit you're using, check the equipment you're using, top up the vaporizer, all those kind of things. But as you say, you really shouldn't be in a situation where you're needing to turn up the gas dramatically during a procedure. Conversely, when might you need to turn down the gas? When might you need to reduce the amount of anaesthetic agent being delivered to a patient? Well, it can be tempting to turn the gas down if there's a drop in the respiratory rate or blood pressure. However, just take a moment to interpret these changes. With hyperventilation, is the ET tube okay? Is there a kink in the circuit? Are the tubes all functioning as they should be? And if you've got hypertension, is something else occurring? Is there a bleed, for example, that the surgeon needs to be made aware of? If the answer to all of these is no, and everything is okay in these regards, then it's okay to turn down the gas a little. Essentially, you're turning down the gas if you feel that the depth of anaesthesia is going too high through those monitoring signs that we've talked through earlier. Finally, let's talk about the situations where you'll need to make a dramatic change to the vaporizer setting, i.e. turning the vaporizer off. So the first of which is part of the normal process of an anaesthetic. You're going to turn the vaporizer off when the surgical procedure is over and you're ready for the animal to move to recovery. The second situation is if you're in an emergency situation. So true emergencies that require immediate discontinuation of inhalation anaesthetic agents come in two forms: hypersensitivity reactions and cardiopulmonary arrest. Anaphylactic or anaphylactoid hypersensitivity reactions usually occur after the administration of a drug, but can also occur during some procedures, such as mast cell tumor removal. Severe and sudden hypertension, tachycardia, arrhythmias, pulmonary and portal hypertension, and cutaneous changes can occur. With cardiopulmonary arrest, as the name suggests, this is characterized by cessation of ventilation and circulation. As far as the inhalation anaesthetic agent is concerned, in these emergency scenarios, the vaporizer should immediately be turned to zero, circuit flushed with oxygen, and appropriate life-saving treatment initiated. So after that last dramatic slide, we're going to bring everything together in a summary and finish off now. So a thorough understanding of anaesthetic inhalant agents, the MAC associated with those agents, your anaesthetic equipment, the patient factors involved with individual cases and how that impacts the MAC, adverse effects that you might see during an anaesthetic, and excellent monitoring of an anaesthetic. These will maximize the likelihood that an anaesthetic procedure will be successful and stress-free for all involved. Please note, this presentation is designed to give an overview of some of the factors and topics to consider when using sevoflurane and isoflurane. It's not designed to be a comprehensive guide to anaesthetics and companion animals. If you require further information on this topic, there are plenty of sources out there. Indeed, there are whole textbooks that have been written on the subject, and I would refer you to these for further information. So in terms of support for Chanelle products, we have a wonderful team of territory managers, and these territory managers are probably our greatest practice support resource. We have Dish, who's based in the Midlands and North Wales. We have Susan, who covers Northern Ireland and Scotland. We have Kelsey, who's in the north of England, Matty in the southeast, and finally Matthew Oakes, who covers the south, southwest and South Wales. You also have myself as the product support manager, and our contact details are available on this slide. Please reach out to us for any support that you may require or questions that you might have. This is a list of references which relate to this presentation. The only thing left for me to say is thank you so much for listening. I very much hope this presentation has been useful and interesting. More information and further CPD is available at vet.chanellepharma.com. To receive a CPD certificate for completing this training, please email vetupdates@chanellegroup.ie. Once again, thank you so much for your time, and we look forward to seeing you on one of Chanelle's CPD sessions in the near future.